this, has a significant effect on reducing medical care costs and has surprisingly been resisted. I'll show you the evidence behind them. This woman is, in fact, the index patient for the ACE study. We are running in San Diego an unusual obesity program using the technique of supplemented absolute fasting. She came in, and in 1985, asking if we could help her with her problem. Our first mistake was in accepting her diagnosis of what the problem was. And you might ask yourself which of the two big photographs on the screen depict her problem. Most people, of course, would pick the one on the left where she weighs 408 pounds. But we didn't know enough to sort things out at the time, and we said yes and took her into the program, and in 51 weeks reduced her weight from 408 to 132 pounds. And thought, well, my God, we've got this problem licked. This is going to be a world-famous Department of Preventive Medicine. She taught us in short order that what is most obvious in any situation is not necessarily the essence of the problem. For instance, in a house fire, typically what you see is smoke billowing out. And if you were so naive as to think that smoke was the problem to be treated, why then fire departments would bring large fans to blow the smoke away. And pretty soon, homeowners would flee the treatment that makes the house burn down faster. And that is remarkably similar to the problem we faced in the obesity program, where we had a very high dropout rate, almost exclusively limited to people successfully losing weight. That's a problem in alcoholism programs and other addiction programs. Keep the idea in mind, because there's a common thread to all of this. Here's her weight curve. It looks kind of like an Olympic ski jump. She stays several weeks at the lower weight here, and then in one 3-week period does something I had not conceived as being physiologically possible. She regains 37 pounds in 3 weeks, and in short order is back over 400 pounds faster than she had lost the weight, and disappears for 12 years. And what happened was that at her reduced weight, she was sexually propositioned by a much older man at work. Hey, Patty, you look pretty good. You lost all that weight. How about you and me making it every week? And regained 37 pounds in 3 weeks. And when I asked her what was going on, she said, well, I think I'm sleep eating. What do you mean? Well, when I was a kid, I used to be a sleepwalker. I haven't done that for years, but I live alone, and when I go to bed at night, everything is clean and put away on the bed and in the kitchen, and I wake up in the morning, boxes and cans are open, pots and dishes are dirty, somebody's obviously been cooking and eating there, and I'm the only one there. I guess that's what's happening. And pursuing the why, why now, why not 3 years ago, etc., led to discovering a lengthy incest history with her grandfather. And suddenly even her job made sense. She's a nurse's aide on the night shift in a nursing home. In other words, she's paid to be awake and on her feet all night long, making sure the old people stay in bed. Somewhat similar case in a few weeks opened up the whole issue of childhood sexual abuse. And when we started inquiring routinely of everyone in the program, it was really overwhelming. I mean, I remember thinking, I must be doing something wrong. I mean, every other person I was asking in the program was acknowledging such a history. I mean, it can't be. People would know if this were true. Somebody would have told me. Wasn't that what medical school was for? And as we went down that path, we stumbled into histories of other kinds of childhood abuse, and then growing up in massively dysfunctional households. And soon the question came, was this at all representative of the general population, or had I somehow collected some bizarre group of people in the weight program? So that was the purpose of the ACE study, to see whether these 10 common categories of adverse childhood experience were at all common in the general population, and if so, how did they play out over time? Some people at CDC became very interested in this, and we spent a couple of years thinking how to approach the problem, and here's the structure of the ACE study. We had a very unusual setting where detailed and unusually comprehensive physical examination was supplied to 58,000 adults a year in this one setting. And so we asked 26,000 of them if they would help us learn more about how life experiences in childhood played out later in life. 17,500 agreed to help us. You should know that we had great difficulty getting the ACE study accepted by the IRB. Otherwise sensible people insisted that we could not use our questionnaire because it was going to make patients decompensate, maybe even occasionally commit suicide, as though there were general agreement that asking people about their lives, particularly in the developmental years, were somehow going to cause them to fall apart at the seams. Finally, we got them to agree on the condition that one of us would carry a cell phone 24 hours a day for 3 years to accept emergency calls from people we would make suicidal. Never got one call. Instead, I have a number of letters, largely from elderly women, one of which memorably summarizes the others. She wrote, "Thank you for asking. I feared I would die and no one would ever know what had happened." So here, the population, the cohort that we studied, average age 57, almost exactly half women, half men, 80% white, including Hispanic, 10% black, 10% Asian, 74% had been to college, everybody had high-end medical insurance. I mean, this was clearly a middle-class population. This was clearly you and me. And we matched current health status here against 10 categories of adverse life experience in the first 18 years of life. And then we have been following them forward for the past 20 years, matching what happened here 50, 60, 70 years ago against current pharmacy costs, ER visits, doctor office visits, hospitalizations, and death. That's the structure of the ACE study. It is both a retrospective and a prospective study. The 10 categories were selected because of their prevalence in the obesity program. Major emotional abuse, basically recurrent humiliation. I ran into a good example a couple of weeks ago. Man telling me that when he was a kid, his father used to line them up and tell him, "You kids ought to just be taken outside and shot." 11% of you and me. Major physical abuse, I do not mean spanking, I'm talking serious beating with fists, sticks, other objects, 28%. Contact sexual abuse, oral, anal, or vaginal, 28% for women, 16% for men in this population of you and me. 22% average for the group overall. Major emotional neglect, 15%, physical neglect, 10%, growing up in a home where one of the members of your household was an alcoholic or a drug user, 27%. Losing a biological parent before the age of 18, 23%. That was interesting because it was clear that the least damaging way of losing a parent was by death, unless that death were a suicide, because that at least offered the potential of creating a protective mythology. My mother would have cared for me if, my father would have protected me if. Most damaging was maternal abandonment. Mom split when we were 3. Most common is divorce, a notably untouched subject that has enormous relevance to childhood onset obesity. Growing up in a home where one of the members of your household was chronically depressed, suicidal, or in the state hospital, 17%. Where mother was treated violently, 13%. Where one of the members of your household was imprisoned during your childhood or adolescence, 5%. All of this, believe me, was a big surprise and hard to accept initially until we checked it and had it confirmed by, in one instance, a sheriff in a little town in Mississippi. Oh yeah, Doc, what she's saying about that family is true, etc. Of course, you would have to ask everybody to understand this, and that's best accomplished by a well-devised, inert mechanism, in our case, a lengthy questionnaire. The A-study questionnaire alone, apart from the medical questionnaire, was 4 pages long, filled out at home, and then followed up ahead of time, face to face, allowing you ahead of time to know where you need to be going. Our most common approach was, I see on the questionnaire that. Can you tell me how that's affected you later in your life? And we listened. And implicitly accepted, although it took us a while to understand the importance of that last part. We were dealing with mountains of information, literally over 400,000 pages of information. We needed some way of simplifying things, and so we created an ACE score, which is the sum of the number of categories of adverse childhood experience. Not events or incidents, but categories. And that could range from 0 to 10. And what you see is 33% claimed none of the 10 categories. 1 in 9 people claimed 5 or more of the categories. And what that means from a physician's standpoint is that every doctor in the country is going to be seeing 2, maybe 3 A-score 5 or higher patients every day. They, of course, will not be recognized, but they'll be the most difficult and complex patients of the day. We found that if any category was present, there was an 87% chance of at least another category being present and a 50% chance of 3 or more categories. In other words, you don't grow up in a house where your brother's in prison, but everything else was fine. And women are 50% more likely than men to have an A-score of 5 or higher, which has everything to do with the increased prevalence in women of conditions like fibromyalgia, migraine headache, etc. So what does this look like in the office? Well, here's an interesting man, a very insightful guy, an amateur psychopharmacologist in a very real way. In another way, a semi-pro saloon fighter. In a different era, this guy might have been a cowboy. Today, maybe working on an oil rig or some other isolating job. When he was 3, his parents divorced. He never saw his father again. When he was 5, his mother remarried. For whatever reason, his stepfather saw fit to beat him pretty much every day. When he was 8, he tells me he remembers one day walking to school and the thought crosses his mind, nobody is ever going to be there for me in my life. When he's 20, he's imprisoned in Rhode Island for attempted murder. Ultimately gets out, becomes a good citizen, works far from home, sends his significant paychecks home to his third wife. Listen to what he has to say. This guy is an alcoholic, a drug user, and a very heavy smoker. Listen to what he has to say about the functionality of addiction, which we usually dismiss as dysfunctional behavior.
20 to 25 years drowning out some poor childhood experiences with drugs, alcohol, cigarettes. Got rid of the drugs, got rid of the alcohol. Next thing I got to get rid of is the cigarettes. And I had no idea that the nicotine played such an important part in keeping that door closed.
In keeping the door closed to?
The memories that I've blocked out with all these years with the alcohol and the drugs.
So you see what's happening to you now as related to what happened to you decades ago?
Yep. I found a way to block the emotions and the memories.
With?
Drugs, alcohol, cigarettes.
Addiction, the unconscious compulsive use of psychoactive materials, or in plain talk, it's hard to get enough of something that almost works. You know, maybe the next mouthful is going to do it, maybe the next cigarette, the next dose, the next woman, the next man, and if not, surely the one after that. The conventional view is that addiction is due to characteristics that are intrinsic in the molecular structure of some substance. You know, supposedly you take heroin enough times and you're not going to be able to stop. I used to believe this. Sounds pretty reasonable. What we found was exactly the opposite, that addiction highly correlates with characteristics intrinsic to that individual's childhood experiences. And the strength of this relationship is extraordinary. The implications for prevention and for treatment programs are profound. Someone named Lee Robbins did a study with American soldiers in the closing years of the Vietnam War, and she found almost 900 patients, almost 900 American soldiers who acknowledged to her, but not to the Army, that they had used heroin daily for at least the prior 30 days, you know, hardcore junkie. When she interviewed them 8 months later after their returning to the United States, what was remarkable was that 94% of them were no longer using heroin. And up in British Columbia, a very imaginative psychologist named Bruce Alexander carried out what became known as the rat park experiments. That when he had rats in a nice, clean, air-conditioned rat room with, you know, 3 square meals a day in their cages, and gave them a bottle of water and a bottle of water with heroin, they overwhelmingly chose the water with heroin. And then he was smart enough to realize that this was a highly unnatural way for a rat to live. And maybe they were under a great deal of stress. And so he created Rat Park, an outdoor enclosure filled with trash and garbage and so forth. Put the rats in there, gave them the same bottle of water and bottle of water with heroin. And amazingly, they selected the plain water. Let's look at people now in terms of smoking. I don't know what it's like here, but it's difficult to smoke in San Diego. You can't smoke on a public beach. You can't smoke in a county park. When you match likelihood of smoking against underlying ACE score, you see a very interesting dose-response curve. The man you just heard talking forcefully about the antidepressant and anti-anxiety effects of nicotine. This plays out here, and the world medical literature documents this extensively, how nicotine has potent anti-anxiety, antidepressant, appetite suppressant, and as the American Indians figured out centuries ago, anger suppressant activity. I mean, they were not burning oak leaves or moss in their ceremonial peace pipes, it was tobacco leaves. Not only that, but those benefits occur within 15 or 20 seconds of inhalation, whereas the risks, which are seriously major, are 15 or 20 years out. I think most of us have some sense that when the screws are on tight enough, yeah, give me that pack of smokes now, I'll worry about 20 years from now, next week, when things have calmed down. When we looked at self-acknowledged alcoholism, the question we used was simple: have you ever considered yourself to be an alcoholic? And match that against underlying A score. You see a very steep curve here. Oh, isn't that interesting? Sit down, have a drink, relax. Well, some of us need a great deal of relaxing. And once again, the benefits are immediate and the risks, which are real, are in the future. And then we looked at injection drug use. And this was really interesting, because at A score 6 and higher, the increase is so huge that it really doesn't fit on the graph without severely distorting the rest of the graph. At A score 6 and higher, that individual is 4,600% more likely to become an IV drug user than is an A score 0 individual. And each of these data sets I'm showing has a p-value of 0.001 or better, oftentimes vastly greater than that. In this regard, it's worth keeping in mind that in America, the most common street drug is generally methamphetamine, crystal meth. What's interesting is that no one seems to recall that the first successful prescription antidepressant that was introduced for sale in 1940 by Burroughs Wellcome and Company was methamphetamine. But, I mean, isn't that stuff dangerous? Well, depends on the dose. You know, 2 aspirins is perfectly safe for most people. 30 aspirins is getting to be a suicidal dose. You know, triple your dose of digitalis and you'd be dead in a week. So does this matter to our treatment of addictions? Should we focus on the underlying problem, or do we continue providing vacuous advice that what's being done is bad? I mean, don't you know it's bad to be fat, etc. Here's a picture from a 1942 issue of the Journal of the American Medical Association, a full-page ad for the very successful new antidepressant methamphetamine. So this may broaden our thinking about the functionality of addictions. Go back to obesity. This man became obese as a child after his parents divorced, and he was sent to live with his violent alcoholic grandfather so his mother could work. And he vividly recalls eating for solace and hiding food in his bedroom. And as he grew obese, he discovered that obesity offered advantages. Now, we know that at some level. You know, think of our expression, throwing your weight around. Although we blame McDonald's for why kids get fat, McDonald's is merely an intermediary technique that's used by some. And keep in mind what I said before about the relationship of childhood onset obesity to parental divorce. Actually, age of onset is the single most important question in understanding obesity. How old were you when you first began putting on weight? And why do you think it was then? Why not 5 years earlier, 3 years later? Why do you think it was? Sometimes people will give you profoundly insightful answers, and the rest of the time you've planted an important seed that can be harvested.
As a child, I remember there was a point, I would probably say all the way from kindergarten to, God, I don't know what grade, but I used to get beat up all the time. All the time. And when I got the weight on, didn't happen.
And around the same time, we had 2 men in the program who were guards at the state penitentiary in San Diego, and they lost between 100 and 150 pounds each, and they made no bones about it. They did not feel safe walking into the cell block regular size. They felt a lot better going in looking big as a refrigerator. This is an important idea, the functionality of what we dismiss as dysfunctional behavior. She's an interesting woman. You know, you all might have known her when she was a little girl who was being molested by multiple people. That, of course, was never recognized by her parents. And she ate to feel better, and then realized that obesity reduced sexual attention. The key point is that we see that what may be viewed in public health as a problem may be viewed by the patient as a solution to problems that we know nothing about. Because, I mean, my God, you can't ask patients questions like that. You're crazy. They'll be furious. And no one will tell you the truth anyway. So listen to what she has to say when she was offered bariatric surgery as a covered benefit.
Ella H. started the interview by spontaneously commenting on the threat she felt when her psychiatrist recommended bariatric surgery to treat her obesity, and offered to sign the necessary paperwork to have Kaiser Health Plan pay for the procedure.
Can I get comfortable first? And then he says, no. He says, when drug addicts come, we take them off of drugs first. And he would take me off of my drug. Food was my comfort. Food. I cope with life with food. And it's really strange tonight. I guess the Prozac's helping, because when I'm taking the Prozac, I will lose a little bit of weight. And I just feel that he was taking away my safety. And so I decided not to even bring the paper to the doctor and have it done, because I'm not ready, I don't think, to get the weight off and know that I can't gain it back and can't be safe again.
It's a big idea that turns up repetitively. She's an interesting woman. Again, heavily molested as a child. She treated that with 3-pack-a-day smoking. And she was thin until she was 35. And she explained to me that with 3-pack-a-day smoking, the cloud that's persistently around you keeps people at a certain distance. At 35, her husband convinced her to stop smoking for health reasons. She quit smoking, the protective cloud was gone, and she was faced with a lot of male attention that was very frightening to her and that she had no experience dealing with successfully. She started eating and quickly got to over 300 pounds from previous slender. At 300 pounds, she went into acute respiratory failure because of all the lung damage she had been accumulating over the years, which was tolerable at a slender weight. She had to go on 24-hour-a-day oxygen. Some years later, we took her into the weight program and reduced her weight by 150 pounds, and we're very pleased. She no longer needed the 24-hour-a-day oxygen. Again, we naively thought we had solved the problem. She again started attracting attention, was terrified by this, and consciously made the decision to eat her way back over 300 pounds and accept 24-hour-a-day oxygen. Here's what this looks like and sounds like. You supplied me recently a lengthy autobiography, a number of dozens of pages altogether. And on the very next to the last line, you said something that I thought was extraordinary. Let me read it to you because I think it's remarkable. I believe smoking 3 packs a day and weighing 300 pounds are not the problem. They're the symptom. Took us a long time to figure that out here, and you just casually drop that as though, of course, anyone knows that. So you are in respiratory failure on 24-hour-a-day oxygen.
Yes.
Major amounts of weight, overweight.
Yes.
And you demonstrated, or we demonstrated together, a couple of years ago that when you had a major weight loss in the OptiFast program here, that your need for oxygen disappeared.
That's correct.
So that, if you lost 150 pounds approximately, the need for oxygen would no longer be there. The weight came back. Most people have very little understanding of why people get fat or regain. I mean, they're stuck with the simple belief, don't you know it's bad for you, etc. And people tend to know even less about smoking.
Yes.
It's labeled an addiction, and as though that somehow explains it all.
Right.
Etc. And you make this extraordinary statement about what we perceive as the problem really being the solution. Can you explain more about that?
Yes. I think I've come to that conclusion. It hasn't been quite immediate. It's come to me over the last few years of analyzing just exactly where I've been and what I've done. Obviously, I was a 3-pack-a-day smoker when I was thin. I didn't have a weight problem until after I was 35. But I've done several OptiFast type things, and I finally came to the realization on my own that the reason I put the weight back on was to protect myself.
This is a big issue that keeps turning up repetitively, that what we perceive as the problem is actually somebody's unconsciously attempted solution to problems that we know nothing about. Moments later, she begins talking about her chronic depression. Most people speak of depression as a disease. Many say it's genetic. Some say it's due to chemical imbalance. There's something to be said for all of that. But what if depression were not a disease, but a normal response to abnormal life experiences? Here's the evidence for that. If you look at underlying ACE score and compare that to self-acknowledged chronic depression, women in red, men in yellow, You see, once again, this dose-response effect. As the ACE score goes up, at ACE score 4 and higher, a prevalence of self-acknowledged chronic depression bumping 60% in women and 35% in men. If we make the same comparison to attempted suicide, very strong relationship. It's moved from a straight line progression to an asymptotic curve here, an exponential progression. And once again, at ACE score 6, there's no way of fitting it on the graph without massively distorting the rest of the graph, because at ACE score 6, there's between a 3,100 and a 5,000% increase in the likelihood of that individual attempting suicide as compared with an ACE score 0 individual. We looked at rape, which I once naively thought was fairly uncommon. The real question is, how does this work? How does what happens to a little girl affect the likelihood of being raped later in life? It's an important question with multiple relevant answers, which answers extend vastly beyond rape. We looked at hallucinations. Now, to find this out, of course, you'd have to ask everybody. I mean, my God, you can't ask everybody a question like that. Why, people will be furious. Why, this man's doing fine. Look how successful he is. He's the governor of, you pick the state. Well, the essence of this here is that at ACE score 7 and higher, there's a self-acknowledged prevalence of hallucinatory activity of 10%. And we thought, well, yeah, but I mean, at ACE score 7, people are for sure going to be using street drugs or alcohol to feel better. And so we corrected for that in the pale bars, and you essentially see the same relationship. But how would we ever know other than by routinely asking? And our vast experience with this has been that using an inert mechanism for getting that information initially is really a key step in getting it effectively. We looked at how it plays out with high-level promiscuity, which we defined as 50 or more lifetime sexual partners. And I slowly came to see that this slide might better be titled Looking for Love. Maybe the next woman is the one who's going to love me, and if not, surely the one after that. And sometimes when relating to one's peers is too threatening, the hope will be fulfilled by a child, or by photographs, or by a farm animal. We looked at the relationship of ACE score to unintended pregnancy and to elective abortion. Unintended pregnancy usually written off as an accident, but we saw that like most accidents, they're not totally accidental. And then, unexpectedly, we found there was a relationship of ACE score to miscarriage of pregnancy. Oh, wow. I mean, how would that work? Keep the question in mind as we switch to biomedical outcomes. Relationship of ACE score to subsequent liver disease. And our first thought when we saw this was, well, yeah, I mean, you're going to buy drugs on the street, you're going to get hepatitis, that's a no-brainer. And that's true, but that's only a part of the answer, as it turns out. Relationship of ACE score to heart disease. Now, everybody knows since the Framingham study that there are certain risk factors for heart disease: cholesterol, diabetes, hypertension, smoking, etc. What most people have forgotten or never knew is that in about 12% of cases, none of the recognized risk factors are present. Well, how do they get it? And when we looked at them, we saw that indeed, unexpectedly, there was a clear relationship of each of the categories that we were studying to subsequent heart disease. But how does that work? Well, it turns out that chronic major unrelieved stress causes the release of pro-inflammatory chemicals, sometimes referred to as pro-inflammatory cytokines. And these cause inflammatory changes in the lining. In the very smallest blood vessels, it causes them to shut down and to turn to scar tissue, whatever piece of organ they had been to supplying. Our first patient, Patty, died at age 42 of primary pulmonary fibrosis, a rather uncommon condition where her lungs turned to scar tissue. Never a smoker, no problem with air pollution. In recent years, it's become evident that a certain portion of cases of primary pulmonary fibrosis are related to this release of pro-inflammatory chemicals. In larger blood vessels, these inflammatory changes in the lining of those blood vessels acts like a magnet, causing the deposition of cholesterol at those places, and ultimately causing partial obstructions of those vessels. We found that when we studied chronic obstructive pulmonary disease, which again had a distinct relationship to underlying ACE score, and our initial thought was, well, yeah, I mean, it's obvious, you smoke, you're going to get emphysema, of course. But there was a lot more to it than that. At any given level of smoking, 1 pack a day, 2 pack a day, 3 pack a day, 4 or more packs a day, obviously the level of COPD, chronic obstructive pulmonary disease, kept rising, but at any given level, not everybody got COPD. Well, what makes the difference? Turns out that underlying ACE score made the difference. Again, the release of pro-inflammatory chemicals in direct relationship to underlying ACE score. So here's an interesting person. This woman is articulate, well-dressed. She has a responsible position in a large university. I mean, she's obviously doing well, and just the kind of person from whom we'd not seek an abusive childhood history. I mean, come on, give me a break. She's doing fine. Of course, we would skip such a history for our own comfort, but we'd also be smart enough to say, well, no need to risk upsetting such a patient. So listen to what she has to say. I once would have totally dismissed the idea of childhood experiences being related to subsequent malignancy, except through smoking. But there's a key piece to this story. So,
can you tell just by looking at me that I was an abused child? Can you tell that I was sexually abused routinely, that I was neglected, starved, beaten? Probably not. You would have to ask in order to find out, and that's not the sort of thing that people typically ask about. The downside of having this kind of childhood is that it translates into health problems in adulthood. At least in my situation it seems to have done. I'm now recovering from my third battle with cancer. Not the same cancer, 3 different kinds of cancer. I've had chronic pelvic pain, migraines, the whole laundry list of medical complaints, all of those sorts of things that are very difficult for physicians to figure out. Growing up that way instills a constant fear, a constant state of turmoil that's just under the surface of a veneer that's fairly thin. little things become scary in an atmosphere like that. And once you've internalized all of that, it's very difficult to let go of it.
She is somehow convinced that her very extensive history of childhood sexual abuse and other forms of abuse is related causally to her having 3 different kinds of cancer. How could that be? Actually, we all know the relevant pieces, but have not put them together. We all know, for instance, that if somebody gets an organ transplant, they need to be on lifetime immunosuppression so they don't reject the organ. Many of us will have correctly heard that one of the side effects of lifetime immunosuppression is an increased risk of malignancy at some point in the future. That's because we're all forming a low level of cancer cells all the time, every day, and our immune system processes them out in the background, and we never know the difference. So getting cancer means either that the rate of production, for whatever reason, is massively increased beyond the ability of our immune systems to deal with it, or our immune systems are for some reason suppressed so that we cannot even deal with the very low level of background production. The question then becomes, well, does it matter whether your immunosuppression comes out of a prescription bottle or as a result of chronic major unrelieved stress? Because one of the main effects of chronic major unrelieved stress is immune system suppression. So there's a very heavy playing out of this in terms of biomedical disease. Plays out other ways too. Socially, we're used to thinking of women as the victims of domestic violence, but that's simply because their victims typically are their children, who are not in much of a position to make this known. And when we looked at the relationship between A-score and the likelihood of becoming a perpetrator of domestic violence, you see essentially the likelihoods are pretty similar for men and women. We look at how this plays out in the workplace. Well, relationship of underlying A-score to absenteeism here on the left, to self-acknowledged serious financial problems here in the middle. Oh, isn't that interesting? Poverty is an outcome rather than an underlying cause. Maybe that has something to do with why well-intentioned efforts like the war on poverty never quite accomplished anything. And here, self-acknowledged serious problems performing one's job properly. So this plays out in all sorts of ways. And what we ended up seeing was that adverse childhood experiences determine the likelihood of the 10 most common causes of death in the United States, and the risk factors for the 10 most common causes of death are the very things we have been looking at all along. With an A-score of 4 or more, the majority of adults have multiple risk factors for these diseases or the diseases themselves. I mean, this is the making of big medicine, of coronary bypass surgery and lung and liver transplantation, of bariatric surgery. It's so easy to become intrigued by the technical wonders of these procedures that we never discomfort ourselves by seriously asking why the problem occurred in the first place. So we saw that many chronic diseases in adults are determined decades earlier in childhood, not by diseases in childhood, as once was the case, but by life experiences. I mean, this has been a profound change in the past century. Rheumatic fever, polio, diphtheria, rickets, pellagra are gone. Whooping cough is starting to return because of an interesting situation where some claim a religious right to avoid immunization, putting the rest of the population at risk by reducing herd immunity. But basically, there has been a huge shift. And we saw that the risk factors now underlying these adult diseases often are effective short-term coping devices. And this is a very important insight into the origins of alcoholism and drug use and smoking and obesity and promiscuity and violence. It's hard to give up effective short-term coping devices, particularly at the behest of someone who has no idea what has gone on. And there's a public health paradox that many of our most common and intractable public health problems are unconsciously attempted solutions to personal experiences occurring in childhood that are lost in time and then further protected by shame and by secrecy and by social taboo against exploring certain topics. I mean, school shooters certainly fall into this category. You know, it's notable that otherwise capable reporters never seem to learn anything about the parents who raised or didn't raise those kids. So we ended up realizing that adverse childhood experiences are the main cause of so-called health risk behaviors, disease, disability, premature death, and healthcare costs. In fact, we have a paper out about 2 years ago showing that at ACE score 6 and higher, there is almost a 20-year shortening of life expectancy. And the question, of course, is, I mean, how does this, why is it such a powerful force? Why is it so difficult to deal with? This helps understand that. These are PET scans of the brains of 2 3-year-old boys. PET scan being a sophisticated kind of X-ray depicting biochemical activity in color and superimposing that on anatomical structure. So, PET scan of the brain of a normal 3-year-old American kid on the left, of a 3-year-old little boy taken from a Romanian orphanage on the right. Romanian orphanages being places where extraordinary levels of neglect were imposed on the inmates. And what you see is large areas of brain where there's no color. And at age 3, when brain is being formed, I don't think it'll tax anyone's imagination too much to consider that maybe what we're looking at is the conversion of life experience into neuroanatomy, and maybe that's why this is so difficult to deal with. So I'll summarize this way. We have this very large base of people with adverse childhood experiences, overwhelmingly unrecognized, producing, we now realize, disruptions in neurodevelopment, producing various kinds of impairment. Maybe this is the socially isolated kid, the weepy kid, the one who has trouble learning in school. And by the time they become teens, they have enough freedom to try to find something that helps. And nicotine helps, and alcohol helps, and antidepressants help, sex helps. And given time, those things that help in the short term produce problems in terms of disease and disability and social problems. A number of people die early. The whole sequence is lost in time, and then further protected by shame and by secrecy. So the question came, what could we do to improve this? How do we get from where we are now to where we could be theoretically? 2 thoughts come to mind. One would be recognizing that these problems exist, and largely that's avoided. The other would be recognizing them in medical practice. And largely that's been avoided. So I had a department of preventive medicine where we had this unusual health appraisal operation of providing unusually comprehensive medical evaluation to 58,000 adults a year in one setting, in the top floor of this building here. First step was filling out at home a very lengthy medical questionnaire into which we integrated the trauma-oriented questions of the ACE study. And this included questions like, have you ever lived in a war zone? Have you ever been a combat soldier? Who in your family has committed suicide? Who in your family has been murdered? A very practical question if you have immigrant populations. Were you ever molested as a child, raped, tortured, etc.? Because of our volume, we were able to feed these questionnaires into a digital scanner that sucked up all of the yes answers. And what we knew before even meeting a patient was really quite extraordinary. I mean, here's somebody who acknowledges being depressed over the past 12 months, has difficulty sleeping, has problems in her family, in her job, with her finances. She'd like to be tested for AIDS. Partner has threatened and punched her. She's no longer sexually active, etc. Chronic headaches, this is an obese patient, chronic abdominal pain, etc. Okay, so what we knew before even walking in and introducing ourselves was really quite remarkable. In other words, we knew where we needed to go further and where we didn't need to go further. And our most common response, particularly with some of these more avoided questions, I see on the questionnaire that. Can you tell me how that's affected you later in your life? And we listened and implicitly accepted, although it took us a while to realize that was part of the action. The outcome was really quite remarkable. As a control group, the same evaluation, but without the trauma-oriented questions in the history, an 11% reduction, an 11% reduction in doctor office visits in the subsequent year. When we moved to what one would correctly call a biopsychosocial evaluation with these trauma-oriented questions, in a 130,000 patient sample, a 35% reduction in doctor office visits and an 11% reduction in emergency room visits. So many people hearing this have said to me, how do you do that? You send everyone to therapy, right? No, we essentially sent no one. Well, how'd you do that? Asking, listening, implicitly accepting. We slowly came to see as a very powerful form of doing. And I only wish I had known that 50 years ago. So the practice implications of this are that a biopsychosocial and a trauma-oriented approach to medical evaluation has been established to be feasible, to be affordable, and to be acceptable to patients. We show that it's realistically possible to move from our current symptom-reactive mode of practice to start dealing with basic causes and thereby improve care while reducing the costs at the same time. And that a trauma-oriented, comprehensive medical history has been demonstrated to have major benefits and is proposed as the routine entry mechanism into all ongoing care, be it medical, psychological, or institutional. So I'll close this way. Adverse childhood experiences are common, but typically unrecognized. Their link to major problems later in life is strong, proportionate, and makes sense. They are the nation's most basic public health problem. And it's comforting to mistake intermediary mechanisms for basic cause. Well, the reason the kid's fat is because that damn McDonald's is there. That what presents as the problem may in fact be somebody's attempted solution to problems we protect ourselves from knowing, and that treating the solution may be threatening and cause people to flee from treatment, and that primary prevention is presently the only feasible population approach. We don't know how to do primary prevention, but it's the right question to focus on, and that change has been resisted by us in spite of enormous demonstrated benefits. If you'd like to get some further information on this, here are some sources. We have some time for questions now. I can't see you because the lights are in my eyes, but presumably, yeah, okay, good. We have a microphone so that other people can hear your question.
Thanks for a great presentation. Although I have semi-facetiously suggested that one of the primary prevention interventions we could use is developing a licensing exams for people to get before they could become parents. I wonder if you could comment on some of the more recent findings that have to do with epigenetics and the impacts both prenatally and postnatally.
Sure, of course. No, very, very well taken point. There are three ways this plays out. First, through various coping mechanisms. Use of nicotine, use of alcohol, use of antidepressants on the street, etc., to try to feel better. They all work short-term with major long-term risks. Second, the conversion into biomedical disease, hypertension, malignancy, etc. The third category of epigenetics is an important category. We did not study it because when we put the A study together in 1990, the word barely existed. That field has exploded within the past 2 decades, and there's no question that epigenetic effects are a very real thing that will be playing out in here. We simply have not studied them. That remains yet to be done. Epigenetics referring to environmental or emotional changes in the function of genetic mechanisms, not in the structure. That would be a mutation. In the function. It would be like having an on-off switch on the wall for electricity versus tearing the wiring out of the wall. Tearing the wiring out of the wall would be akin to a mutation. Epigenetic changes would be like having an on-off switch on the wall. Structure of the gene is unchanged. Its function is altered.
I will say the website for the Harvard Center for the Developing Child has some very elegant descriptions of these epigenetics.
Okay, the point is the website for the Harvard Center for the Developing Child has some useful information there. An excellent book on the subject written by a man named Peter Nathaniels, Nathanielsz, and the title is The Origin, Life in the Womb. The subtitle is The Origins of Health and Disease.
This is Larry Green. I'm from right here.
Louder, please.
Yes. That presentation was at once one of the most refreshing things I've heard in my entire career and one of the most depressing things I've heard in my entire career. And I'd like to ask your opinion about primary prevention. In your opinion, is there sufficient evidence now to justify substantial expenditures and effort to implement candidate primary prevention stuff in real towns, real communities across the country?
Okay, so the question focuses on how one might do primary prevention. And the issue here is that we're really talking about having an effect on tens of millions of people. One of the things that's worth keeping in mind is the low-hanging fruit there is that huge portion of the population that has had no experience growing up themselves with supportive parenting. Parenting is a crucial issue with all of this. You want a clear idea, a couple of terrific books. Congressman Patrick Kennedy has just written an autobiography that came out about 5 days ago. I've read about a third of it. It's quite remarkable. Another book, the psychologist James Garbarino has written a book called Lost Boys, and more recently another book called Listening to Killers. He spent a lot of his career interviewing people on death row. The essence of that book is that killers are not born, they're made at home. So anyway, primary prevention. The thought occurs to me that many of those people with no personal experience with supportive parenting might do better if they only knew what it looked like. So how could one demonstrate to tens of millions of people what it looks like? Obviously not by books or pamphlets, etc., nor by home visitation programs, important though they are. They simply attack a minute piece of the problem. So what if one were to develop a pilot for a serial television program, a soap opera, if you will, that had woven into the storyline illustrations of what supportive parenting looks like and how it plays out decades later, contrasting that with illustrations of destructive parenting and how that plays out decades later. You know, you think back to shows like Mr. Rogers' Neighborhood. You know, what was that about that was so enormously popular? Well, for several million kids every day, it supplied the presence for an hour of a supportive adult male. So I am hoping that somebody is going to be interested in developing a pilot for such a program. I'm convinced of the huge value of theater in some of the most difficult aspects of primary care medicine. We certainly saw that in the obesity program. I didn't have a chance to talk about it, but I remember hearing the theatrical director, Peter Sellars, not to be confused with Peter Sellers, the English comedian, make the memorable comment, the role of theater back to the time of the ancient Greeks has been to help people speak about the otherwise unspeakable. Because, hey, you know, I'm not talking about me, I'm talking about what's up on the screen there. And there's a very, very big idea in that. I'm working with a couple of groups that have some interest in developing such a pilot to put on the American Indian Television Network, partly because storytelling is an essential piece of Indian culture, partly because that's an enormously difficult population, and if one could figure out what worked there, it ought to work anywhere.
Dr. Felitti, I know we have many questions in the audience. We have time for about 2 more. We'll take one there and then one more up here. So.
One more over here. Okay. Just real quickly, this is very important stuff, and this relates to the last 2 questions, and that It seems to me that we have to think about the alternative explanations issue, so one of which is the third factors issue that's related to the epigenetic one. The other is the direction of causality issue.
Say again the last sentence.
The direction of causality issue in that, for example, we have evidence that even report of childhood abuse is malleable and changes over time. So I'm just curious whether you or anyone else you know has collected prospective data that supports the importance of ACE factors in all of these variables, because that would allow you to...
You mean such as starting at birth and following through?
That's right, yeah.
Yeah, no, that would be a very important thing to do. I mean, that would really be a major piece to do. I totally disagree in terms of validating this, the proportionality of it, the repetitiveness of it, the fact that the patients themselves understand this really makes this pretty inescapable. Arguments, well, you know, it's just relationships, etc. Yeah, that's nice if you want to get away from this subject because it's threatening or distasteful. We're way, way beyond whether this is valid. The problem that we're facing is whether we wish to deal with it or not, and if so, how would one deal with it?
Hi, I just want to thank you for proving the case of the need for family therapy intervention in primary care settings. We work with lots of individuals, but we fail to see the opportunity in these brief formats for doing important family work. And your research just by and far validates the need for people trained in that in primary care. The other thing I'm seeing is a lot of our patients who are coming in who are very sick are caregivers in their systems. We have a growing aging population. We're expecting more and more families to do the caregiving. We are putting these individuals back into the role of needing to care for those people who harmed them. Do you have any ideas on how we can help the aging population and this middle-aged group manage these expected roles in a healthcare system that offers very little for caring for our aging population?
It's not something I have much experience with per se, but if you'd like to read a good book on the subject that has just come out, of all people, a remarkable surgeon named Atul Gawande, Gawande, has just brought out a book called Mortal Lessons. It deals very much with that subject, and I would recommend it to anyone. Really an extremely well done book.
Thank you, Dr. Felitti, for being with us today. Please join me in thanking